You good there, John? Yep. All right, good morning, everyone, and welcome to the Finger Lakes REMAC meeting. Tuesday, November 17th, year 2020. It's 9:08 a.m. You know where your viruses are. So it's been an interesting few weeks. I missed a week of it while being out of the country, but I'm not so quarantined in the country as it was safe. But it's been quite an interesting time, and we'll talk about it a little bit. Let's approval the minutes. A motion from anyone of the voting members? Oh, yes. I'd like everyone to rise for a pledge of flag. Thank you. It's not on our list, and I follow the list as a. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. All right. Approval of minutes. I need a voting member. Second. Good. Okay, we're going to try to move along because we've got a fair amount probably to end up discussing. Program agency coordinator. Well, why don't we go to conference recap? Or are you ready? I'm sorry.
Yeah.
And you said, will you move?
I moved because I got to control the thing. So, obviously, we've been busy like many of the doctors and other agencies have with this coronavirus planning and being coordinating resources and the such. It's consumed all of our waking days and times, and it's quite an evolving beast right now. So there is supposed to be several additional policy statements coming out in the next couple days with some direction on respiratory and response factors and that kind of stuff. So as soon as they're released, we will pass those along to the committee and to our agencies. So that's about it for that piece of it. As Jack alluded to, conference recap. Our conference was held on the 21st, 22nd, 23rd of February. It was attended by roughly about 100 people. Some pretty good responses. People liked the variety of the subject matters. And many of them are already looking forward to next year's conference.
You can I make a recommendation for next year's conference?
Nope.
Maybe just maybe a little session on viruses.
Oh, okay, that makes sense. Well, hopefully we're already through all this before that. And it's not an issue. But
John, how does the 100 compare to last year?
it's about on par. It wasn't a vast decrease or increase at all. Unfortunately, with the current state of all the online recertifications, that is kind of shooting the in-person classes, and it's a slow death for the in-person classes. But I mean, that's what we've been dealt, so we'll continue to offer that as long as we have the ability. We might have to scale it back or change the way we do it, but we'll keep evaluating that.
Excellent. Hang on a second. So, let's see the conference recap. All right. So, COVID-19 is obviously a hot topic. As of the COVID-19 tracker this morning that I found, there's a total of 183,500 confirmed cases worldwide. Of those, there are 96,400 roughly active, 79,800 are recovered, including, fortunately, Tom Hankson's wife. There have been fatal cases of approximately 7,100. China was obviously the most seriously hit with 80,000, Italy about 27, 30,000. My information as of yesterday, there's one case in Ontario County.
One.
And
Yep.
Friendly home,
friendly home,
according to Quebec County,
and 10 in Monroe Livingston. I haven't heard of anything more. For those of you that don't know the virus, it's a coronavirus. It looks like a crown underneath the electronic microscope, hence the name. It's a single-strand RNA virus. Its proteins have an affinity for the epithelial cells of the lower respiratory tract and the GI tract, hence the symptoms. It's very similar to what we saw in SARS and MERS, severe acute respiratory syndrome, and the Middle Eastern respiratory syndrome. You can imagine if the virus is going to attack the respiratory and GI tract, it's going to present with cough, GI symptoms. Fever is really kind of number one. And then the typical viral syndrome, body aches, things like that. Kind of sounds a lot like a flu, which makes it kind of difficult to differentiate. The overwhelming majority of these cases are mild, cold, maybe little body aches, okay. Elderly tend to not tolerate it as well. Those are the ones that are winding up with pneumonia and the end-stage ARDS type finding the lungs full of fluid, severe dyspnea, things like that. It's respiratory droplet, person to person. There may be fecal oral. So, 6-foot distance from your patients, wearing masks, gloves, gowns if we have them, good cleanup afterwards in cases where there's high suspicion. It seems to be cutting down on the transmission to healthcare providers. The key right now, because we don't have a vaccine, we don't particularly have a treatment, is social isolation, what are they calling it, the social distancing, right? And again, if we can prevent this transmission, keep the numbers down, we can prevent this thing from getting a whole lot further, or going a whole lot further. So, between the federal government, the state government, the restaurants, meetings, all those are shutting down, just trying to keep this spread. There appears to be some resistance once you've had it, maybe 4 months to 2 years, no one's really sure, but the key here is really not to get it and not to go that route. Hopefully down the road we'll have a vaccine, but it may take a year or so. There are 2 antivirals that are being experimented with now, probably some others, and we may see some luck from those. Obviously, if you get sick or any of your crew members get sick, keep them home. We really need to avoid spreading this. Other than that, I don't have a lot to say about the virus, other than, clearly its numbers are low. When you look at seasonal flu and some of the other SARS type diseases we've had, H1N1, Ebola, the numbers are way down. The death rate tends to be a little bit higher. I think that's probably where some of the scares are coming from. So that's all I've got to say about COVID-19. The bottom line is, and this is really where we need to be going, is it's not the first of these viruses we've seen, and it's clearly not the last. So let's learn all we can from this virus and use it in the future. So, how to protect our providers, how to cut back on the patients we're transporting if we can, how to keep it from spreading, relying on our agencies for some support equipment-wise, and thinking ahead to have more supplies down the road. Oh, I know you are, believe me. I'm not saying that in a bad way, and I know you are. Sir?
So I think probably a good thing to discuss is it seems like each of the healthcare systems in the region have handled it very similar, but there are some little nuances in how they want patients presented to the hospital and how they want them, to what area transported. So, I can speak for Wisconsin. Originally, they were going to put a tent outside in the parking lot. They've opted for, there's like a conference room that's been converted into like an ambulatory clinic, so dividing the cases presenting either mild, moderate, or severe. The moderate and the severes are going to be going into the ED.
Where's the actual triage taking place?
So process-wise, and it's probably similar, I can't speak for the healthcare systems, but it's probably similar, 100% should be called ahead. The triage nurse will then, probably ask some key questions as to symptoms they're having and severity, and to see if they're appropriate for this ambulatory clinic. I shouldn't say ambulatory area of the ED. So the idea with it would be mild cases, so cases not requiring any specific diagnostic testing or treatments such as like nebulizers, any aerosolized medications, chest X-rays, interventions, or just kind of the word well, fevers, cough, no hypoxia, maybe even be wheezing a little bit. Those patients could go to an ambulatory area of ED.
Who's screening them?
So they're screening them, when they call ahead, they're speaking to the triage nurse at the desk. If there's any question, they're gonna pop it over to the ED doc to say, hey, should we bring this to the ambulatory area or should it come to the ED?
So are you holding up the ambulatory area as a dedicated emergency department and with EMTALA implications or no?
So it's part of ED. You're going to get seen by an ED doctor, ED nurse, ED. So it's still the same. It's just a physical, separate area where they can come in, come out, keep isolation precautions without, still the same exact ED treatment, just for patients that need a limited set of intervention or assessment.
Is that additional staff or are you just redeploying staff?
We're pulling from the main ED, and Christy may be able to say more about.
Right now, we're pulling from the main ED, and the main reason is we need to move people out. Once we get our staff back up, with spring break right now, we've lost a lot of our staff. The plan is to try to put an additional staffing out there, but it's our float nurse that we would put in the waiting room anyway, and we're not putting anyone in the waiting room.
I think we're all gonna have to learn from each other as we go through this.
Yeah.
One of the things that we're doing is, shutting down a lot of elective areas, including cardiac rehab. So we have cardiac rehab nurses today that are being, asked to report to the employee pool, and then the idea would be to utilize, those nurses at a screening point outside of the physical ED. I don't know about you guys, but we've actually seen a calm. We've seen very low volumes, and I think it's because we haven't seen the surge yet in the community, and people are taking the message of not coming to the ED with non-emergent complaints.
I took one out of precautions to Highland Sunday. It ended up being a positive test for flu and negative for COVID-19. But we did the PPE thing. The patient was actually in gloves and a mask prior to our arrival, which whatever. I didn't have to put the mask on his face, so I was okay with that. Highland brought us into routine triage, and then immediately with our PPE, their PPE, the patient and theirs, immediately into an isolation room with negative pressure. And in the case of this gentleman, he had a fever of 100.5, cough, respiratory distress, altered mental status. He was sick.
We all realize that we do not have nearly enough negative pressure to put all these patients.
Did you call the head?
I did call ahead.
Okay.
And everyone knows, I don't know if this was already stated, but no running debts should be running as you come through the department, right?
Well, they should not be running nebs in the ambulance if it's at all possible. We want to avoid nebs. It's just going to aerosolize and see more. Don't, if you need a sputum, I don't think I need to talk to the medical people, but we don't want to do sputums. We want to try and prevent the transmission of this as much as possible.
So the other thing is that maybe more about this, but I believe Europe in this was really supportive of the concept of community paramedicine with this specific activity. There should be a little bit more freedom or latitude, for calling that direction and say, hey, listen, hopefully those mild cases that you're talking about that would ordinarily go to our makeshift isolation area of the ED, probably wouldn't even need to be transported. It's really just kind of the ones that are,
But how are they going to get tested?
They
they don't all
testing.
need testing. That's the thing. It's
So I hope to have that material from the state available today. It's not gone through the commissioner's office yet. But that
I
is,
was just about to, I've got it pulled up right now. I'm pretty sure it's on the same thread.
but it hasn't gone through the commissioner's office, right? But Based on symptomatology, if the patient appears well, they do not need to be transported. There's actually going to be a handout that the state has come up with to give to the patient. If your fever spikes higher, if this, and a number, a hotline number to call, and a local number to call. So this should be available in the next few days. But yes, not every patient needs to be transported. If they look well, they're not dyspneic, they're not particularly hypercorrexive, they don't have real high fever, they don't need to be transported.
When did you get that? Could you send it to the?
Oh, believe me, it's gonna go to everyone.
Yeah.
I just am not in a position to send it out yet because it hasn't been approved by the commissioner. And our current commissioner, any commissioner, would probably not be very appreciative of getting out multiple copies until it's the final copy. And I feel bad because I'd love to give it to you guys today.
Because the CDC too has changed recommendations on healthcare provider PPE and what the level of risks means. It's not congruent with New York State at this time. So on the call Thursday, New York State specifically stated, we realize the CDC came out with new guidelines today. It's the table about low, medium, high risk based on source control, based on the healthcare provider control, with the acknowledgement, I think, that they know we don't have enough N95. So what is the current recommendation that if a person would to present with an influenza-like illness that EMS wears N95 or a surgical mask?
If they're not received,
We were told that 95s. That was my talk. I was on a phone conference yesterday for an hour and a half with State of Ours executive.
Yeah, and
how they're dealing with it through.
Yeah, there's discussion, constant discussion about this, but just so you guys know, the current model for healthcare providers is that as long as there is source control, the patient has a mask on. If you have a mask on, unless you're doing aerosolized procedures, intubation, CPR, NEPs, you are still considered to be low risk. New York State doesn't agree with that. New York State says if you're going to be swabbing the patient close contact, then you should have N95. We are going to run out of N95 masks. Like, it's not when, it's if, or not if, it's when.
I think a lot of that is a kind of downplay for first responders because we can't get the equipment across the board. In Seattle, they told the same thing right out the gate.
Yeah.
We didn't have the N95s. Look at the exposures they had to responders. And usually it was because they were behind the ball that all these agencies were cutting 60–70% of their staff. Because somebody would come in 2 days later, they get notified and everybody would be quarantined.
Yeah.
You know, 60% of our staff, it's a lot of people. Well, everybody here.
You decimate the workforce.
Right, and so I think they're just trying, they realize there's no surge of supplies coming very shortly.
Yeah, they can't, I think they realized, the CDC did, that they can't give a recommendation that we can't fulfill.
Right.
there's gonna be a post-corona registry, like 9/11, for all of us that were exposed during the,
Keep in mind, we want to limit the exposure, so if you can send one crew member in, keep law enforcement out, keep fire department out unless you need the lifting assistance.
Yeah.
Because a lot of those calls, you're probably going to send one provider in, evaluate them, and hopefully give them instructions and have them sign off.
There's the REMAC and put it out to the counties.
It's going to come out from the state in any day, either later today or tomorrow, I really hope. It should have come out yesterday.
It should have been out already. Maybe we just stayed in something else.
Listen, we're not, if we want to start talking that, we were going to run out of tape.
It's on Zuckerberg's desk, I know that.
Yeah, so it'll be out the next day or so, and that will give you guys some support, some backup.
Yeah, they're certainly talking about eliminating the tiered response efforts, meaning they're not going to send law enforcement, they're not going to send fire to under certain circumstances. They're encouraging 911 centers to ask blunt questions like, are you or anyone else in your family under quarantine? So I know the 911 centers are addressing all
Deb, has
their
Ontario
stops.
County gone to that other card, that infectious disease card?
Use QA, so
Yeah,
I do know
yes.
that they are
Okay,
using
good.
it, and Dr. Blake had some input on what they're asking.
Jim, do you have any idea what Wayne County's done?
We've gotten the first step of the change. There's talk of some more from priority to come out with further changes that I know that they're.
Because we instituted that in Seneca County a couple years
I know
ago.
Monroe has already stopped setting fire and police on calls.
Dave Yates did that about a week ago here, right?
Yeah, we haven't changed any responses yet.
No
But
fire
they are
on
asking
anything.
questions.
Need to limit the response, because if we do have a case, instead of sending in 6 people, let's send one person in who's properly attired.
And to a certain extent, they're also talking about, having your primary crew member doing a doorway assessment. Instead of, jumping right into the residence, start your interview at the doorway. And how are they presenting, and do you need to take further precautions?
The patient doesn't look ill, they're not dyspneic. After once we get this state paperwork out, you will not have to transport it. And again, if there's any questions, utilize your online med control. Everyone here's got access to med control.
So the most current recommendations for the COVID-19 from the Department of Health there's a link posted on the Finger Lakes Region's website, and the most recent policy statements are there as well.
Can we standardize some stuff across the counties? I mean, Wayne County's doing this, we're getting advised of this. Ontario County's telling us this, it's confusing our providers.
Right.
We've already found a couple that slipped through, based on, we're just screening for general illness and you traveled. Okay, well, we got a chest pain, with shortness of breath, with a fever of 103 for 4 days.
Unfortunately, we're only as good as the information we're getting, so.
I think the state material will help.
The track that we've tried to take so far is not create our own documents and to share other people's documents. If the information is out there, it's going to be the same resources.
Yeah, the initial algorithms were based on travel to level 2 or 3 country, just, so everyone, I'm sure you're aware, but as of Thursday last week, there is now a level 2 global travel advisory. So in us living here, we are now, so there's no really, it's community, there's community transmission now.
Right, but getting that information to us in the same format would be a huge help. The other issue is if you guys would support, I don't know, is the community paramedicine on the table for him, for the commissioner?
The Medical Standards Committee is actually actively supposed to be discussing and creating some sort of mechanism.
So there's a document, Dr. David Off and I just discussed it, and there's another discussion going on with Med Standards right now about, how did Lou put it in an email yesterday, the additions of any procedure that we need now.
Yeah,
With
that's
the
not going to go
executive
very well.
order, with the governor's executive order, it loosened the approval processes and has made a lot of this, able to be conducted pretty rapidly.
I think what we're going to see
probably
is
some sort of
more judgment in who to transport and not to transport and where to transport. And you're going to see more, if we get to a point where there's vaccinations or medications need to be given, there'll be some leniency in that. Are you going to see true community paramedicine pop up this week or next?
I don't think true, but I think one thing you want to think about is even if, I know New Rochelle's doing it. They got a group down there that's basically doing a form of community paramedicine. They're sending out the fly cars, basically they're doing the emails.
Oh, instead of sending an ambulance.
Correct. They're making a determination if they want to transport or not. A lot of people don't have.
Honestly, you would first respond in a non-ambulance vehicle quite often.
Mhm.
And there's no reason why a first responder of the appropriate level can't say we don't need a transporting vehicle here.
The community paramedicine side, though, you can get compensated for those calls. So I think the billing part of this,
Yeah.
instead of sending, your ALS providers out to do these evals, and there's no recoup on this later.
So we've discussed at every discussion, reimbursement. If we don't transport a patient, how does the service get reimbursed? We've discussed this over and over and over again. Everyone understands that's a huge problem. Whether or not that's going to get fixed this week, because that's not a state or even, that is an insurance, that's an insurer problem.
Right.
And no one can just tell them, hey, you got to start paying for this.
Yeah, it's a code, though, for community paramedicine.
I don't think we're going to see that.
Right.
I don't think we're going to see that. I think what we may see is pressure on the insurers to pay for a response without transport. And transport to alternative destinations is another possibility that you'll get. You could transport to an urgent care center and get reimbursed, not yet, but hopefully within a few days.
This is just going to push ET3 to a reality as opposed to a pilot project.
Well, ironically, there was a survey that went out last night.
That transport to alternative destinations is definitely going to need to be a consideration moving forward because, at least RRH's, approach to this is really looking at developing kind of some alternate triage centers outside of our ED, potentially, picking a couple urgent cares in a couple locations that will specifically be, referral centers for these kind of walking well, really not requiring ED evaluation with definite concern for COVID.
Right. Urgent cares in the state of New York are supposed to be registered with New York State, and the local health authorities are supposed to know their capabilities. I know most of the urgent cares that I've been affiliated with have done that. Whether all of them have done that or not, I don't know. But they should all be capable.
Well, we're actually looking to get some potential new spaces. Like one of the spaces not currently operational, but being looked at least is the former SOTUS location. So while not a technical urgent care, may kind of open in the interim to function as such. So just looking at some alternative solutions.
Which would make a lot of sense. But right now, technically, if anyone's transported there by ambulance, they can't get reimbursed, and that's a huge problem. So that's something we have to be working on. Since we've got you on the line, would you like to talk to us about what's going on over at Clifton Springs?
So Clifton Springs is one of the other potential areas we're looking at is setting up for kind of receiving these patients. We're really hoping to have some better answers in the next couple of days of what we're going to be putting together operationally between SOTUS, Newark, Clifton, what types of patients we're going to be trying to get to each of those locations. At this point, Rochester Regional, if you contact us, go through our transfer lines or referral lines and such, we are directing a lot of our traffic at this point to a couple urgent cares in Henrietta, Wilson, up near RGH, and out west of the city in Batavia. That's why we're really trying to get something together in the eastern region. But at this point, Wilson Center and RGH is now a drive-through testing location. So, really able to move some volume through that setting. So, looking at what we can operationalize out of Clifton, Newark, SOTUS, and a combination of the three to try to, meet the needs of what we're going to see coming in the eastern region.
Anything different as far as EMS arrival and triage at Clifton Springs?
At this moment, no. We will probably have some communications coming out in the next couple of days when we really get an operational plan together that we can get out to you guys. What would be the best way of distribution of that plan to ensure that we hit every appropriate agency?
Send everything through John Van Auker.
Perfect.
And
Thanks, John.
We'll blast it. Newark Wayne, anything different going on over in that neck of the woods?
Yes, we have a full disaster plan pretty much completed. We are going to be, I'll send all the final copies to John as well. I've spoken to some of our large EMS systems already. So the update is we already have our trailers in place. We are setting up a respiratory pod outside in the circle, outside of the emergency department, with 2 or 3 different entryways into the ED. A huge help from EMS would be that anyone that is ill or significantly ill is going to be a call ahead, and we are going to be sending very sick respiratory patients through the decon door, and we'll be going into rooms 19 through 14 where we'll take care of very ill patients, not in our typical trauma room. The walking well are ones that are mildly hypoxic, probably I would say 88% and above, or that appear well, and they're in your rig and you are transporting them, they will go to our respiratory pod. We'll be asking you, our traffic flow is going to be going one way through the parking lot, and we ask that you go through the one-way, and we'll have that well marked. We have hired extra security guards that will be outside, and you will drop them off at a respiratory pod, and we'll evaluate them, and hopefully those are the ones that will be able to discharge quickly.
I'm going to
And,
ask, okay, sorry.
And if you have all of your other comers, your chest pain, your belly pain, ones that are typically sick, you will bring them to the regular ambulance door, and we will do our regular triage.
Perfect. I'm going to ask that you guys, John, sit far enough away from me, that you keep him up to date, particularly if you could send him a quick blurb on what you just told us, and keep him up to date on everything as it changes, so that we can get it onto the website and get it out to everyone. And it'll keep all of us kind of in the loop as far as what's happening.
That would be great. We have not started the outside plan yet. We're waiting for the numbers to start increasing before we put it into action. But I do assume possibly by this weekend or first of next week, we'll probably put it into action. So I'll get everything to you before that time and our start time as well.
I know we're all gonna be busy and it's an additional effort, but if you do that, we can get out to a lot of other folks for you. So that would be helpful.
That's great, thank you.
Thank you. Anything else from any of the hospital systems?
We're gonna be actually sending out maps, so you know where you're gonna go in, because to get to this walking.
Send us a copy,
Yeah.
send John a copy, or get it up on there.
Yeah. I try to explain how to get there and you get lost.
So John, can we, how difficult is it for us to get this material up on the website?
It's actually not.
And it's pretty easy for everyone to access it.
Yeah, it's pretty easy. We'll have to see if we can create a specific page maybe for.
That's what I was wondering, almost like a blog site where people can just sign in really easily. I don't know
Well, I'm
how
not sure we're gonna be able to do
Oh.
that piece of it, but we can certainly post all the local information
to,
online.
okay, just so we can keep people informed. Perfect. And obviously forwarding emails on to everyone, stuff like that. Anything else?
I'll throw a good point. Just so we learn, the hospital's what recommendation were that the unit should be, the ambulance unit should be doing decon at the hospitals. And so the hospital should have appropriate decon supplies available, you know, a mop if they need it, you know, to the floors, you know, so multiple hospitals can each get this stuff available.
You guys able to hear Dr. Glick? For those of you on the phone, Dr. Glick said that, yeah. So the recommendations are that the EMS agencies, when they transport suspected patients, do decon at the hospital facility, and just request if we can have some of the decon materials available to them.
Could you define decon materials that they would require and what decon they're expected to perform?
They're probably going to need access to the anti-agent wipes, maybe some bleach or other substance to mop the unit if they need to, and red bags. Am I missing anything?
You said red bag?
Red bags.
What would you use? Current guidelines are to red bag anything unless it's still bloody or otherwise.
The red bag decision is still up in the air in New York, as far as I know. It was on the material we were discussing. So until I hear otherwise, I'd probably recommend red bagging. It is probably not a major expense in the scheme of things, just until we know for sure. Sound appropriate?
Certainly easy enough to have the wipes and other things together. I mean, if you guys want red bags, we're certainly happy to give you red bags, but I definitely wouldn't support all of the EMS red bagging all of their materials, leave it with us. That's certainly not the direction we heard from our infection and prevention folks at the moment.
Now, we're just talking about suspected cases of COVID. We're not talking about normal cases, so we're not talking about multiple red bags. Okay.
Yep, I'm aware.
Okay, all right. I mean, I would prefer red bag stuff at this time, but certainly if your facility does not want it, we don't have the authority to interfere with that. All right, so moving along here. Actually, Finger Lakes,
So just for my understood about the behavior of this virus, you know, you know, this definitely has potential to climb, you know. Usually week 1 cases, look at some case reports from Italy. Week 1 cases were low fever, cough, you know, generalized malaise. Second week were mild respiratory, and a lot of those ARDS cases didn't present until week 3 of it being predominant in the area. So, you know, we're not seeing, you know, we're not out of the woods with the bad respiratory cases. Those are probably yet to come. So
We're not out of the woods for bad respiratory cases from influenza yet.
yeah.
So no, I think we need to be prepared for all of that. There are limited respirators, ventilators in this area. There's limited ICU beds.
So not to beat the dead horse, but the community paramedicine, whatever we're going to call it, the treat and release, the assessment on scene, this is important to do it now so that the hospitals aren't inundated with these patients when those bad cases do come. But,
I would be very comfortable with my services calling me today, asking me, do you think this patient needs to be transported? And I'd be very happy to say no if I felt they could stay at home. With appropriate instructions, that if they get worse, they need to call and be reevaluated. That's my personal decision. It's up to you guys, what you guys want to do for med control. But I think that's the appropriate thing to do. I think we're going to get supported by the state and federal government on that real soon. But I got no problem doing that right now. So, anything further on COVID-19? Just a little topic on our agenda for today.
Did we change students, right?
Excuse me?
I'll address it.
Okay.
All right, FLCC.
Well, we've been busy.
No.
No. Because right now, currently, I have DOH rules, Fed rules, CDC rules, SUNY, and FLCC rules we all have to go by for courses. And nobody seems to agree on the same thing. So, as of right now, all the hospitals have shut down for any students. Our senior paramedics are finished with their hospital time. Our junior paramedics, we have put them on hold because they would have just started going into the 911 center and to the RGH overflow, which at this point, there's no sense teaching them our IVs if they're going to be able to do anything with them for the next 2 or 3 months, or however long it takes to go in. Jake is trying to realign that schedule so that we can do something different. The AEMT students are really the only ones at this point in time that have been hurt by this per se, because they were not all done with their clinical time. But if you talk to, with talking to the DOH, Jean Taylor has said in numerous meetings and that we have to become creative, wasn't her exact words, on how we're going to finish things out. So we do have the availability to do simulations on SINMAN for various illnesses or whatever you want to call it to try to get them through whatever they got to do. RT was shut down. We had a few students left to do RT, different things like that. So that is part of that for the AMT. The basics only do ride time. I shouldn't say only because I don't mean it that way. The thing we can do right now we're doing, because some of the basics had gotten some calls in. They all do a minimum of 12 calls, so what we're doing is looking at their books. The calls that they do have, then what's ever left between the 12 and that, we are going to do simulations for that so that they can get through their system. And I believe the state will approve that. We've got to get that okay with us. The one area that we do have an extreme amount of problem with right now is the senior paramedics, because they are in their capstone where they have to do 20 calls. Some are close to being done on their 17th and 18th call. Some are not, and are like still at 5 and 6 calls and that. Most of the EMS agencies, short of North Seneca, unless you've changed your mind at this point in time, have all shut down for students. So there is no ride time available for them. And it came out from COANS, which is the accreditation body for the paramedic program, where it says programs must be aware that simulation cannot be substituted for their capstone internship. So Jake and I are trying to look at this, not knowing how long this is going to last. I mean, we even contemplated last night at 10:30 when we were really talking about this. Do we delay the graduation, or how do we make it so that the students are eligible to graduate in May, which would be their normal time? do we have to extend it out so that they can get their capstone finished at some point in time? Those are all things that we're looking at because we are stuck right now. The other thing for the colleges with following the SUNY system is originally they wanted us to do everything online, and I had to go explain to the provost and a lot of people that really aren't familiar with EMS that when they are learning their skills, it really is not an online, here's the traction, here's how you do it, go for it, deal. So they have allotted for nursing and massage therapy and the different ones like that. We can do a 4-to-1 lab is what they're considering it. 4 students to 1 instructor and have it classified as a lab. So I have one class right now that has 25 students in it that we have now rearranged the schedule so that there will be 5 labs for those, or 6 labs for those students with lab instructors, and we're going to rotate through. They will be doing skills, and they will also, they have been given their material, they've been given, or will be given the PowerPoints, they will be giving their take-home exams at this point, those type of things, and then they will be required to come in for the classes, and then they will be doing what we consider to make the college happy as labs. So we are trying to be as creative as we can to get these kids done. And like I say, that part of it, the provosts are kind of, and assistant provosts are kind of like, we really don't know. I did talk to them because we do have the Hobart Wayne Smith kids that come to the class here as part of that 25. Half of them are HWS students, and they are, the ones are staying. They are doing their courses online, but they said they would stay as long as they could finish this course in May, to the fact that they have 6 or 7 EMS providers right now for the HWS team, 4 of which are graduating. So if we can't figure out a way to help them get through, they will have no EMS program starting in September when they come back. So they've agreed for the lab sections as well. A couple of them have gone home because parents have said, no, you're coming home, which I can't argue with that. But for the most part, that's where we sat. Our biggest concern right now is what are we doing with these paramedic seniors?
No, I may have heard this answer in the paramedic committee meeting, and it's probably escaped me, but what's the difference in COAM's accreditation versus the paramedic students meeting minimum state requirements to be allowed to test? So basically, I guess my question, simpler, is that they have to meet the COAM's accreditation requirements to be able to take their state exam.
And your program would not be accredited.
However,
National
under the circumstances, I think Amber's gonna have to be more flexible. And I know New York State's been talking about actually expediting some of these people through the program to get them on the road. And COAM is just gonna have to figure out that they didn't have any control of this going to be.
I understand that, but I have to go by the directive I got this morning too, because Jake got it yesterday.
Right, so we're not accredited, but they still qualify for the tests.
They will qualify for National Registry Law.
But not national, but they'll still be New York State.
But the problem with the new practical exam, I'm not sure where that will set.
New York State's also discussing, I think we're gonna hear more in the next 2 days.
But they would be able to take that class that Heidi does, and they'd be able to sit, what is it, the 8-section class, and then be able to sit for the new practical, and then sit for National Registry.
Possibly.
So what do you need from the EMS agencies? Basically ride time?
Right.
Can you provide PPE for them?
I only have the face shields with, or goes over the ears. with the surgicals. I mean, we didn't have a lot here. We started out thinking we were gonna do that Monday night until everybody started shutting down. I had enough here to give, and we can pull it across, away from the basic, or the juniors right now, if we're gonna deter them from riding. So that we could probably give every ALS, the seniors, could probably get about 8 of them. I mean, I only had them here for use in class to demonstrate, you know, PPE and stuff like that for them. So it's not like I have 40 boxes. And Jake was like, well, just order everyone a box and we'll give them to them. And I'm like, where do you think I'm gonna get them from?
You're just talking to paramedics.
You're right, you're talking 20 paramedic kids. so I mean, that's our biggest
So the
dilemma right
region's giving
now.
it to agencies.
What's that?
So if agencies are willing to have the riders, the region's allowing them to ride. We haven't polled anyone saying you can't ride.
Yes, we have been notified they can't ride. They've been notified by various agencies.
Right,
They have
what I'm
shut
saying is
down
the
meetings.
region hasn't come out and said, students, you can't ride.
No.
It's been agency specific.
Correct.
Okay.
So, I mean, Jake told them last night if they can still find ride time to go for it. And not to be, because I'm all for this as well, because we've had a couple of them that came from the Syracuse region that yes, AMR will not take them. TLC right now is on the borderline whether they're gonna shut down taking them or not. They're still taking them this week. But we have a lot of smaller agencies.
Who covers if they get exposed?
It will be probably the agency will cover something and the college will have to cover something. I mean, there's.
But you can't prove where they got exposed.
Yes.
Right.
I'm going to interrupt for a minute. I understand that Ed Major from the Department of Health is on the phone. Ed, is that true?
Yes, hi, good morning, everyone. I've heard a little bit of your discussion. I know there's intense focus on COVID response activities, and there's just a couple things I want to say about COVID. It's a constantly evolving and changing and evolving situation, as we know. I have just a couple bullet points on it that I'd like to discuss. There will be an all agency EMS agency should be getting an email from the Bureau. We're going to have a agency leader conference call. I believe that's going to be Thursday. There should be an email. It's going to have to be flexed a little bit, probably related to when it actually gets sent out to all the EMS agencies. But Ryan and Steve are working on that so that every agency leader can get direct information via phone from the Bureau. Keep in mind that we're working on an additional 3 or 4 policy statements related specifically to COVID-19. The policy statements that are on the Bureau website, even though they're dated like February something, the links that are within those policy statements will give you the current, most up-to-date guidance. The only other thing that I want to emphasize is that PPE shortages, if EMS agencies are burning through PPE as all the EMS agencies are. The objective is to exhaust your supply chains. If you cannot get it through your normal supply chains or looking for additional supply chains, then a request to your county Office of Emergency Management should go in. If the county cannot fill the request, then they should put in a New York response ticket. The details of that specific request need to include very specific sizes, quantities, specific items that are needed, the current burn rate that the EMS agency is going through related to use of PPE, and additionally, how much PPE or what the quantity that they have and when they anticipate running out. So I would make sure that EMS agencies are looking at their inventory, looking at their the quantity of PPE equipment that they have, and if they anticipate backlogs, as everybody's getting backlogged on that, get those requests in as promptly as you can. But OEM and the New York response ticket needs very specific, detailed information related to those items that I spoke about. If you've got any questions about all of that, I can answer them. I think you guys covered enough about COVID, but can't emphasize enough the priority to protect the first responders from the law enforcement side, from the fire side, and EMS and other most vulnerable patients. You're going to see skilled nursing facilities and nursing homes either do some type of medical screening related to temperature monitoring as EMTs come into prior to coming into the facility. We're working on a little bit of guidance related to that because we're seeing variations across the state. Some people are doing a full medical screening. Obviously we don't want to have delays to patients, but the expectation from the Bureau standpoint is that the agency that is staffing the units, their folks are fit for duty and looking at screening individuals prior to going out, maybe a good implementation. But we'll have further guidance on that soon, and those policies are going up through the executive process at this point. In addition to that, I think you talked a little bit, there's a bunch of emergency regulations that are going up through. We'll have more details to follow on those. And I can't emphasize enough PPE and provider safety. So if there's any questions, I'm glad to answer them. If I don't have the answer, I'll get you an answer. But thank you very much for all the effort that everybody's doing related to this unique time that we're in.
And there are some questions.
And I got one of our crew, well, a couple of our crews were talking. They want to know if when we expire all our PPEs, the fit test N95s for them, do we start mutual aid because we don't have the proper gear to assess these patients?
Well, I think that is, you know, our emphasis is to ensure that you get the proper PPE, that it's in date. I know that they're making some modifications to can you use expired, can you not. Provider safety is the utmost priority, and I would say to you that we have to adopt all methods to try to ensure that our crews are provided with the proper PPE and that your response ready for those situations. So again, I would emphasize, get your request in. If you're running short and your burn rate is high, as everybody is high, get those requests into your Office of Emergency Management. Potentially, there are others that are out there that may have available resources within your provider network. Look for other resources that could share potentially, but we don't want folks going into scenes and being unprotected and then just being quarantined. We've got a significant rise in the number of providers across the state that are currently in quarantine. We would encourage people to look at their continuity of operations plans and ensure that folks are wearing the PPE prior to entry into COVID type calls and respiratory calls, et cetera. So there's a lot of moving parts. There's a lot of information that is changing, and we're trying to get you the most up-to-date information as rapidly as we can. So I hope that answers the question, but we want to make sure that you've got proper PPE.
And we're out. We're out of the larges and extra large 95s. We do about 10,000 calls a year here.
Are you guys using N95s for any general response to any respiratory complaint?
Only if they're high risk.
As determined by what risk assessment system?
We're following the CDC guidelines.
So if they have a fever, you're putting in that 95
If
minutes.
they got a fever, shortness of breath, or generalized illness, our crews are going in with an N95. And the reuse thing just came out 2 days ago, and we've been doing this for a week now.
The CDC changed the country to a level 2 travel advisory based on their algorithm. We are all, if you have influenza-like illness, you screen in as a PUI.
So we are totally out, thinking that we do about 10,000 calls a year. 10,000 calls a year, we're going to strain the rest of the agencies, especially for our...
Correct, yeah. Al, have you put a request into OEM at this point, or no?
Yeah, Deb and I have talked a couple times, and I can tell sitting at the table, she's trying her hardest and doesn't seem to be getting anywhere.
We're having a hard time with the state getting that order in because they keep coming back with, well, we need to know this information and that information.
New York City has all.
Right. Do you have a specific New York response? I'll call you afterwards, Dale, and certainly Deb if you want, but we can try to assist with that. We need to get that into a higher priority.
Yeah, because they take that right with our hand sanitizer request too.
My brother was a paramedic alone.
And believe me, the New York response tickets that are coming in, obviously are significant. They are triaging, what's in the current stockpile. I know that, and I don't know the numbers are changing, but the burn rate is so high that even with the stockpile that is there, the quantities are somewhat limited. I know that in addition to that, they're deciding, making a critical decision related to whether or not to be able to use expired stuff and that kind of stuff, which is way above my pay grade, obviously. So when we get further direction on that, we'll let you know. But yeah, let's talk afterwards, sidebar, and go from there. If you want to get a call, I can try to work through that a bit.
Okay, thank you.
Hey, Ed,
Yes.
there's a lot of folks that have SCBA masks, and there's a lot of SCBA masks available through fire departments. With simple adapters that were available commercially, you can use reusable biofilters. It would cut down a lot of use of the N95 disposables. Do you have any access to any of those supplies?
I'll tell you what I got. I have zero. But we can. That's a good suggestion, Jack. Can you give me the specifics on that, and I can send that off too.
Yes, I can, because I'm pretty sure that your National Guard has a pretty good stockpile of those for CBRNE, which I think we've just about gotten to at this point.
Gotcha. Understood. Yeah, I know it's an issue, and it's one of the highest priorities that the state is working on. Not specifically BEMS, but OEM and state emergency management, and everybody is intensely focused on it to ensure that all the responders are protected. So I appreciate that, but I will. Yeah, let's talk afterwards. Let's talk afterwards, and we can try to figure out what that ticket number is and see if we can get that to a higher priority.
Anyone else have questions for Ed Major?
The simple face mask versus the N95, is it putting it on for all high-risk patients with the quantity limitations right now, or?
So the question is simple face masks versus the N95s.
There's a lot of discussion about that. I think that policy decisions are being made. As soon as we get further, we'll send that out. At this point, the expectation is to, there's sometimes differences, Jack, between what New York, New York is taking a higher standard than, sort of the CDC. CDC was relaxing things a little bit on certain inclusion criteria versus New York State was still sticking with N95. So they're debating that at the policy level at this point, and as soon as we have clear direction, we'll make sure that information gets out. But for now, it's the N95, yeah.
With any close patient contact, 6 feet or less.
Yeah, close patient, yeah, absolutely. And, I think you mentioned it earlier, trying to minimize, not putting additional responders in few situations where, police don't need to be going into a scene that, I know it's depending on the circumstances, but limiting the number of people that are going in, limiting the people that are in the back caring for the patient. Obviously, it's the, anything with aerosol medications or looking at multi-dose inhalers. There's a ton of stuff that's going on at protocol level, policy level, alternative destinations. I know you guys have talked about that a little bit earlier. So this is a freight train that's moving fast, and there's a lot of updates that are coming. And as soon as that guidance is up, we'll get it out and go from there.
Well, hang on tight.
Yeah, buckle up, everyone. It's a very interesting time. So again, thank you. Specifically, if you have anything else that you need guidance on, if I don't have the answer, I'll run it up. We'll get the answer, and we'll make sure that we're as responsive as we can. So our the bureau side of the house, we are, our staff is basically 100% dedicated right now to COVID-19. If you're not getting responses on normal operational things or delays in those items, we apologize, but we'll get to you as soon as we can.
All right, sounds good, Ed. Thank you very much. You're going to be online with us?
Yeah, yeah.
In case any other questions come up. Well, I think we're getting near the end of the COVID-19 discussions. I'm not sure what RSI and RSA has to offer us today, or do you want to delay till next meeting?
I want to include today if possible.
All right, please do.
Hi, everybody. It's good to be here. I was supposed to be in Florida right now, but so that didn't
Just
happen.
came from there. I got to tell you, it was wonderful.
Overrated. It's overrated. Only St. Patrick's Day in Florida, so it's overrated. So the main thing that I want to talk about today is the RSI committee. We've been talking for many months, if not years, about regionalization and putting a document together to answer all the questions that people have, that we've been trying to answer ourselves for years. I did send it out to all the REMAC doctors. I hope that the REMAC doctors got it and looked at it. John, you just send that, right?
He's all set up.
Yep. I can send it to you right now.
Can you?
Okay.
You're just talking about the materials that went out with the initial meeting stuff like 2 weeks ago or a week and a half ago?
That is correct.
Yep, got it.
So there's a couple things.
Looks reasonable.
Yeah, there's a couple things that I wanted to just go over real quick while I have everybody here. There's a lot of hot button topics for the RSI committee. The biggest hot button topics was grandfathering, credentialing, qualification, from other agencies. If you're an RSI provider in another region, what do we do? Why can't you be an RSI provider in this region? Other question was who ultimately is in charge? Is it the agency medical director, is it REMAC? And then the third thing, the other thing was how do we get a pool of resources in terms of funding to allow us to have doctors come to testings and all that. So this document tries to answer everything. It answers the qualifications for initial classification of agencies and providers, also to remain an agency and a provider. One of the things that we were lacking for many years up until now was we not having formal documents to apply for qualification into the initial class or to qualify to become an agency. We have addressed that. We have made forms which are attached to this. Another thing we have is we have an attestation form. We didn't have that either. Another thing that we do is John created a letter with my signature on it. For years, we didn't have a yearly way to keep track of all the RSI providers. What we're doing is we're having each medical director of the RSI agency just write down, I support Carlotta, blah, blah, blah. Now there's going to be a regional form. I realized we didn't have that. So what I'm asking, and I'm not going to go through all this, then we have bigger things to talk about. What I'm asking is a motion to approve this document and the corresponding documents and allow this to become the guidelines for the RSI program in the Finger Lakes region. Seconds.
I'll second that. Yeah, I thought the documents look good, Mike. I was working clinically those nights, so I wasn't there.
Well, technically, you can't make the motion.
Somebody make a motion. I'm asking for a motion. I'm asking for a motion. Sorry.
Yeah.
Dr. Glick made one. I second.
I have to be honest, I was out of the country. I have not seen those documents.
Right now.
I thank you. However, any discussion, there's a seconded motion. All right, so there is a second motion, and I'm looking for all those in favor. I trust my colleagues, so we'll make it unanimous. How's that sound?
Thank you so much.
Still sending.
So if you trust me?
Yeah.
Put your name.
We got some retests right
Guys
now.
online, you still there? We heard a lot of beeps.
I'm still here. Marita had to jump off to get into a Newark meeting.
Okay, yeah, we heard some beeps. I wasn't sure if they were people coming on or people leaving. Are you okay with that motion that we passed? I apologize.
Yep, no objection from me.
I really do apologize. We're just not used to having the phone folks here. I wish it was video, but maybe we'll work on that for down the road.
We also
Can't make two crews, Jack. They got phone.
Mike, what else you got for us?
So we also have a couple of retestings to do
Yes.
today after this meeting. Hopefully, once everything gets back to normal, we were going to have a discussion about another class. I know there's 5 or 6 people that were approved in this class that couldn't take the class. I also had some interest in maybe having some more providers take the class. So obviously that's on the back burner, but we're going to get these people through, and then I'm looking to have somebody make a motion that if the people that are testing today successfully complete the didactic and the written portions, they are be allowed to practice in these regions are staff providers with the medical director permission. I know we have to come to REMAC to have them be approved.
I think under the circumstances, I think that's pretty appropriate. But, need a motion?
So moved.
Second? Second. Any further discussion? How many
No
people-
objection.
Perfect. How many people are retesting today?
There's gonna be four testing, one's not showing up. We'll talk offline about that.
Okay.
And there's someone gonna take the written, and I don't know if she's coming, I can just handle that myself.
The
there should
written,
be-
yeah, and we agreed that
Yep.
if she passed the written, she's cleared.
Yep.
And, I'm sorry? Oh, perfect.
There should
So
be
we've got,
three,
said maybe
there should be-
four today?
There should be three, two original, one retest. And then two written, it's three written if she shows up, two if she doesn't. And that should be it. And then we can talk offline about the other
Matt,
ones.
do you have to go? Or do you think you'll be able to stick around?
I think, what time are we gonna do?
Now.
I told-
As soon as we get done with this.
I told people to
Yeah,
come
we've got
about
probably
10:30 or
another-
11.
No, I'm
One
good.
Scott?
I gotta leave in 15 minutes, I got a time shift.
Oh, okay, so we probably won't have you here, but if you can stick around for a few minutes. Bill, you want to stick around for a few minutes? You're not ours.
Not credentialed.
That's okay. That's all right. I trust your experience to work with us. You can sit in with one of us and kind of assist us if you can stick around. That'd be great. Right, and then any of the advanced paramedics, if any of you can stick around for a couple of minutes, that'd be helpful.
That's my understanding.
I'm gonna stay for a little bit.
So, well, yeah, we can get those guys knocked off. In fact, if you and I run two separate stations, swap them, we can get it done pretty quick. Do you trust us?
I do.
Okay.
I can test one of them now, they come to Thompson. Meet me there.
Do they have to get their temperature and all that taken first?
Probably, just see.
All right, sorry, guys, this is not a common time, whatever. Anything else from our side, RSA?
Nope, that's it.
All right, excellent.
So Jack, just one comment, kind of, it's advanced practice.
Well, that was next.
We have sent out and asked for comment to the committee to reevaluate the ALS clearance process or credentialing process.
Did you see that I sent you tomorrow?
The recommendation to the medical director that they be cleared process.
Well, we're going to set a system-wide standard.
Yeah, system-wide standard.
System-wide standard is allowable, but it's not an individual. So we're going to create that.
You're going to pass the attorney?
It must.
So more to follow at the next meeting.
It must be okay because Monroe County has one, Melrose has one, so.
Oh, man, it's like grid on your head.
Yeah, well,
Okay.
Yeah, okay. Also with the advanced practice community, we are actively working on SCT protocols. I have Matt and Jason are chairing the portion of that, since I'm not an SCT provider and I'm not an SCT agency. They're working on a policy statement, correct? And we should have that, draft for that relatively soon.
Yeah, we were gonna send it out to all the REMAC before the next REMAC, so they have time to review it.
Perfect. Guys, thanks so much. All of you.
And once we do that, we will.
Dave, I know you, Dave still? Dave, oh, thanks for kicking
We
this stuff too.
will have hopefully a draft. I think we're not going to reinvent the wheel here. We're just going to probably cut and paste of the protocols.
Yeah, that's very appropriate.
The other thing that we're working on was the concept of a almost like a clearinghouse, if you will, for medical control. We talked about it at length. I think the first question we had was, can we do this for every medical control, or is it more useful and more practical to do it for specialty care, meaning RSI, SCT, etc. I think the general consensus was it's probably best to start with specialty care and see the feasibility of that. What we were looking at is having some doctors who will be kind of like what the universities like, doctors that are on call, that are able to answer phone calls for RSI, SCT, medical control. I know that we are working, John is working diligently to try to talk to Strong Hospital and Dr. Cushman to get medical control clearance at Strong for RSI. Currently, we do not have that. And so we're relying on the emergency or agency medical directors and hospitals that we are not transporting to treat these patients, which sometimes may delay care, especially as a doctor who is not as familiar with everything, gets on the phone and doesn't want to give orders to someone not coming to the hospital. Good thing is that we have doctors from hospitals on the committee. I've been including Dr. Coleman in this. I've included all the doctors. I'm also including Dr. Shore from F. Thompson. Another good thing is I talked to Dr. Weiss.
Pulmonologist?
Yeah, no, he's the
Home critical care.
home critical care at Thompson. He is very excited and very happy to look at the NCP protocols and give feedback and help in any way possible. So I'm hoping that by including these physicians, not only physicians on this REMAC, but physicians off REMAC, but have their own specialty.
Dr. Galton from Mercy Flag is very anxious to look at it.
I included him on the RSI stuff too. So I'm hoping that by this we get more input, and also it gets us a little bit more freedom, and they know that what we're doing is proper, what we're doing is best for patient care, and that they will be more not as reluctant to give orders if we're not coming to the facility.
We've talked about that concept for years, and I really think that would be the best, at least for the SCT, because you really want docs that are involved, interested in knowing protocols, and medics to a certain extent. And I can't speak for all the other docs here as far as how much they want to take on, but certainly there's going to be some docs that will be more willing to do that.
So the next step is feasibility, who to get, how to get it, what to use. So we're going to make.
So on the technological side, we added a talk group to the Region to Ontario County system, the radio system, 8500. Talk group 8500 is reserved for medical control. It's a totally separate side. It's different from everything else. It's only for medical control. We opted to add that so that there would be something like that down the road, and also allow docs from other regions to talk to other docs within this region. We were looking into a grant to try and provide radios for REMAC docs, and I think we kind of got sideswiped with COVID-19 a little bit. But the reality is there's an app you can put on your phone. The county doesn't want to pick up the cost because it's expensive, but if someone else, hospital-wise, might be willing to pick up the app. As long as you got access to the internet on your phone, you can talk directly on that system.
I think that's where we're leaning towards. I looked into that talk group. I don't know if people know about that. That's something to think about, but we'll have more to follow.
I was able to talk back from a sailboat off the shore of Grenada. No one knew where I was. Yes, wasn't as nice as Florida.
So will that work for counties that aren't on that system?
What's that?
Will that work for counties that aren't on that Harris system?
Well, if you have access, that system has pretty wide coverage. I've been able to talk back from portable radio at Watkins Glen without any problems. I think that area, that system you guys put in really is quite impressive.
Is there a channel name or is it just Talk Group 8500?
Talk Group 8500?
So the app for Clarity is at $900.
How much?
$900.
Per license?
Per license, yeah.
You know, if the hospital is willing to pick that up for each of their docs.
I think it's a one-time.
I think it's one time.
But then, any agency that, let's say doesn't have, 800s in the region, they could just have that app.
Yeah, which would be our whole county.
And they're looking at it, you have to have a license for every rig, basically.
Whether you go to the app or whether you just buy it at 700 megahertz radio. But that's down the road. We've got the availability of making it relatively easy to contact Med Control for SCT transports. So we can definitely make this happen. Just take some legwork.
That's all.
Thanks, Mike. You guys, please extend our thanks to the rest of the committee. Let's see. So that pretty much covers all those reports. Mercy Flight?
Aaron, are you still on the phone?
Yes, I'm still here.
Anything to report?
Just a couple quick things. I know many of the outlying officers are still on the call, but just one thing to think about is they're putting up their pods or tents outside the emergency department. So please let us and air doctors as well, like that know if there is going to be in any proximity to the health tent or potentially any change in the health application or the availability of its use. We've had a couple that have been up for testing purposes, and we run across and want to make that as a request that if at all possible.
Your temporary structures don't tolerate it.
What's that?
Temporary structures don't tolerate the rotor wash very well from previous experiences.
Yeah, I know.
I'm going to request that John put that out as a notice to everyone.
That'd be great. Then the only other thing is our education day is scheduled for the 8th, which is the calendar of the 8-week month. We haven't made a decision yet, but we'll be covering, but better let everybody know if we have to reschedule a date or we have to change. But we'll let everybody know.
Sounds good.
That's all I have.
Thanks, Aaron. Like that.
Thank you.
Yes, so hopefully Del Lago still exists in September, and we do have our critical care conference scheduled there for the 11th and 12th of September. Obviously, subject to change depending on where we sit with the coronavirus outbreak. We do get calendars too that you can easily mark off the days for your quarantine, so please feel free to take them.
Really not long?
Yeah, yeah. And we did suspend our ride-along program and any current open houses or outreaches in the planning zone classes just for the safety of everyone involved. So.
Makes sense.
Yeah, more stuff to follow as things progress, but hopefully we can have a conference.
Hopefully. All right, very good. Old business? John, you had one comment there?
Yep, so just letting the REMAC doctors know that the region and the REMAC have been officially released from the lawsuit that we were involved in. So our side of it seems to be in our past now. So we've got that documentation and we're all set to move forward.
All right. New business.
So one thing, Walworth Ambulance submitted us a request late yesterday afternoon to, they're in the process of doing a name conversion, or I guess the name's already officially done, according to filed at the state level. But they are in the process of putting together a package to consolidate essentially 3 services into one. Union Hill, Marion Ambulance, and Walworth Ambulance will essentially become Western Wayne Ambulance Incorporated. Their request at this time is for the Walworth Ambulance to decrease their level of service to BLS from the paramedic level. And I've already been in discussion with them and outlined that they need to, the process they need to do to follow in turning in their narcotics with their original certification. You know, the final inventory count signed by the pharmacy and the appropriate other forms that they need to fill out. And then all that needs to be sent to the Bureau's Western office for this fully to take effect. So we've been in communication with them and they understand the process. I will be sending them a letter with all that information this week so that they can proceed. Thompson Hospital has a EMS education session scheduled for March 14th. It's going to be a trauma lecture and May 14th. No, I'm sorry, May 14th. May 14th. So it's a trauma and a stroke lecture, as long as everything remains quiet and stable, and this I'm sure will continue. If it changes, we will let everyone know.
With the Walworth becoming Western Wayne and incorporating those other agencies, is the C1 automatically given?
Nope.
Okay.
So that will, they'll have to apply back to the full council for review, and they'll have to resubmit if they elect to go back to ALS. They have to resubmit an ALS plan, and they'll have to come back to this committee for provisional ALS approval so they can continue with their narcotics planning. So, it's essentially going through the planning for a new agency or a new CON process.
Does it sound like that's what they're gonna do? Are they looking to
As
get
far
back to-
as whether they go back ALS is, from my understanding, and Jim's been involved in it a whole lot longer than I have, that's still up in the air and being hashed out. Because Wayne County's flight car service is up there providing coverage right now.
Their ALS called way low.
Yeah,
like
the
40
reason why they cite that is they said they've had, like 3 narcotic administrations in the last calendar year. And there's really
It's gotta
only
be cost prohibitive, yeah.
there's 1 or 2 individuals that are providing the service, and they're working full-time on the flight car, the Wayne County system. So, to them, at this point, it's not worth keeping the service up with the added expenditures.
Makes sense.
The plan for the agencies, they've been meeting for a number of months, and actually goes back a couple of years, between Marion and Walworth. So they want to change the name of Walworth, which they've done, and then they're going to transfer Marion CON to it. And then the Union Hill thing just kind of came up, and Union Hill voted to transfer their CON to the new entity, to the new group also. Although there's no active plans to take calls in the old Union Hill CON district, which is the town of Ontario, the town of Webster. But it's just, they're just going to transfer to it kind of for future. But, so initially be Walworth and Marion.
Gotcha.
And it'll go to the council. They plan on doing it in May if they can get together.
Well, we're gonna have to reschedule our May meeting because the scheduled date is actually Memorial Day.
No,
For that meeting,
no.
so we need to adjust that.
So, in the answer to public or community paramedicine changes, the last update I saw was, this is not mission critical, I do not have time in the midst of a public health emergency, as one member put it from medical standards. So they will not be pushing community paramedicine. There are some doctors.
Did you see the comment that just came through on that email, Fred?
That's the one that I just saw.
Oh, no, there's one that came in 2 minutes ago.
Not mission critical.
I'm trying to download it, what does it say?
Some thoughts on the national scope of practice, being our base, not our ceiling. EMTs can give injections in New York State, why can't they give vaccinations? EMTs can place OPAs, why can't they place an agile or other similar suprarobotic airway with just-in-time training? Teach CFRs and EMTs and paramedics how to use spacers with MDIs to allow them to administer certain medications, allow CFR and EMTs and medics to provide antibiotics. They can already give PO Tylenol and ibuprofen by mouth for BLS and IV for ALS. Allow AEMTs and medics to use PICC lines with just-in-time training in instances of their cardiac arrest. And finally, ventilator thoughts. With patients on a home vent or trach, why can't the EMT just bring along the patient's vent? This is equally an ALS call type. Again, would require just-in-time training and permission from the medical director. And that is from the one of the CMAC physicians, Dave Kugler.
Ed, are you still online?
No, we gotta jump off.
Oh, okay. It seems to me that under the governor's, whatever he did,
Executive order.
yeah, that EMTs, if there were a vaccine, would be allowed to give it. I'm pretty sure that this happened, even when we were worried about smallpox and some other things. We'll get some updates on that, but right now we don't have a vaccine or a treatment, so.
So, Jack, just to back up to the Walworth, I
Yeah.
need a motion from the REMAC doctors to support the decrease in nominal service. First, Dr. Glick and Dr. Talbot. Okay.
All right, any discussion? I mean, it sounds like it's taken a while, they've put their numbers together, and with the usage, it just doesn't make sense when we keep the narcotics on board, so. Anyone else have a different feeling? A vote, all in favor to allow that? Anyone still online?
That won't affect your
I think
Medicaid one card though.
they've all had.
I think we need to check, because if Walworth is in EMS agency, they have ALS equipment on their car. They would be able to disconnect.
Have an off the counter shift.
They'll have to come off at the end of the shift. It's an agency of the vehicle.
Yeah, just
Well, that's what I was asking. So we're going to do that. Calls out of service for
All right, gang. Does anyone have a Kurt Bowen or a Michael Alicia as part of their organization? Kurt is from Jamaica, New York, and Michael is from Woodhaven, New York. And they have both had their certifications. One was revoked and one was voluntarily surrendered for violations of Part 800.3 and Part 800.16. Don't need to go any further detail, but it's now been passed along. I just want to pass one other thing along for your own information, for your family, friends, for your employees and patients. Telemedicine is quite readily available under a lot of insurance companies. They can always call telemedicine 24/7, and that's also a way of getting information whether you should be calling 911, whether you should be going to urgent care or to the emergency department. So that's another alternative for people to utilize for healthcare questions. And then Don, you missed something you want to bring up?
I just have a couple of things, and we're trying to decide. I've had calls from several agencies asking for us to hold it. We are doing some CMEs on the pediatric, safe transport for the pediatric and lifting and moving and emergency vehicle safety and mental health and EMS. We're all crazy right now. Because they are required as new non-core requirements and will be required for anybody restarting after July 1st. So we've had a response for people that are interested, signed up to come, and they're questioning whether we should still hold these or not.
My gut is that we should probably suspend them until summer or fall.
Some of them,
Well, you
some of it
can't
they
do
can't.
it. You can't do it.
What was the dates again?
There are various dates.
So they're coming out.
March 25th, April 1st, April 22nd, May 16th.
We've got March 18th.
What else scheduled tomorrow?
I think under the circumstances, I think we should not be doing this. Does anyone disagree? I mean, we've got to do everything we can to kind of stem the passage of this virus, especially amongst our healthcare providers, because we are a very, very limited resource. And I think to take any chances I think it's dangerous.
Jack, one final thing is just as a point of information for this group, our executive committee, the program agency directors have all been tasked with looking for means of consolidation with other regions. So we are in the process of trying to figure out who our dance partner is going to be and who we feel that we're going to work best with. So more information will follow on that, but is what the state's looking at, reducing the amount of contractors that they deal with. So we were all tasked with finding other regions to partner up with and to reduce the number of contractors. So the initial plan is to keep all the program agency folks and everything as it is today, just we'll have a different mothership, so to speak. So as we learn more, I will pass that along.
Deb, I'm gonna put you on the spot again. Do you know of any stockpiles of, forgetting about the N95s, which we know, but the non-disposable stuff, which was probably getting a little bit old, but would last for quite some time. I think going back to the old stockpiles of World War II, that stuff's probably mostly trash. But there's stuff in the 60s and 70s, there were gas masks, there were canisters, stuff like that. A lot of the fire departments that have gotten new SCBA's probably held on to some of their masks, especially the ones that gave out to individual firefighters. And some of that stuff's available, which could put to good use.
I think we gave a lot of it back, a lot of the masks back, or they've been sold off to other people. Because a few years back, they did provide masks for like law enforcement. Because you had to still maintain ethic testing.
Yeah, maybe you could, maybe ask your colleagues in some of the other areas. You know, it's just because with, like with the N95s being out of stock, we're gonna do a good job. You know, Pappers are still functional.
Good contact to use.
So, you know, anything that's out there that we can utilize, we may have to, so we get some more supplies. I appreciate it. Let us know. We'll move around. Do you have contacts, Seneca, I mean, some of the other county folks? You can reach out to them too, because, you know, they're busy. All right, thanks. Guys, anyone else have anything they'd like to contribute? All right, motion to adjourn.
Motion.
Yeah. Second. All right, all in favor? Adjourn. Everyone stay well, keep your distance.